Welcome, everyone, to the Systemic Care Leadership Learning Community. This is Denise Solzbach, and Beth Joel and myself host this learning community. We are kicking off the federal fiscal year series with Beyond Impact Statements Addressing Behavioral Health Disparities. We see so many new 2019 grantees joining us. Welcome, everyone. This learning community is offered monthly through webinars and is designed to support systemic care leaders in all roles, whether you're a project director, a PI, a social marketing communication lead, a family leader, youth leader, leaders in different content areas. All leaders are welcome. We do try to address topics of importance to systemic care leaders. We will highlight throughout the year, particularly issues that you should be paying attention to in your cooperative agreement, such as the Behavioral Health Disparity Impact Statement. We are here to be an ongoing resource for all of you grantees, as are your technical assistance leads from the TA network. While this learning community does include many grantees, our learning community is open to folks with or without systemic care grants because we do address issues that are important to system of care expansion and sustainability, regardless of whether or not you receive SAMHSA funding. We like to have as much open back and forth communication as possible. We see that you are very good at that with your introductions and your chat box. We really encourage you to continue to use the chat box throughout today's presentation. We will save time at the end for Peter to respond to your questions, and Beth and I will make sure we'll be tracking your questions. We'll be moving them over to a presenter chat box so that Peter can address them at the very end. Please also make sure you stay on the line at the very end of the webinar. We have an evaluation survey. We really value your input. We strive throughout our entire continuous quality improvement process throughout the entire year we have with you coming up, and we also are very interested in topics that you feel we should be hitting as well. So please do stay on the line and complete the survey at the end of this webinar. We also want to introduce you, those of you that are new to our learning community, Ideas at the Institute is our learning management system platform. The learning community is able to be more dynamic and interactive through this platform. It's really a digital hub where you can register for webinars, download resources, seek technical assistance, and interact with your peers. And when I was in your shoes implementing these grants, the peer interaction is what made the most to me in supporting my efforts. So please consider joining. You will be getting follow-up emails from me in two ways. First, everyone who registers for today's webinar will receive a follow-up email from me with the recording and instructions to sign up or how to join our learning management system. Those of you who are already enrolled in our learning management system and our learning community, you will also receive the recording from our system, from Ideas at the Institute, will be sent out to you in your inbox as well. Just going to show you a little bit of what the learning management system looks like. As I said, it's an online training. It also includes social marketing feeds and more than just our learning community. You'll be able to be exposed to our other learning communities as well. There's an icon to click on to join the learning communities. There's a catalog of all 10 of them. And this is what it looks like once you click on. You'll see our learning community is to the far right with that arrow towards leadership. That's our picture to direct you to where to find us. And then once you get within our learning community, this is just a sample. It's of course content. You can see upcoming webinars, you can see recorded webinars, and you can see resources that we've downloaded for you. So we really encourage you to use this interactive component of our learning community to get to know each other better and to communicate with Beth and me. Our presenter today is Dr. Peter Gamache. He is from the Turnaround Achievement Network, part of University of South Florida, and he is one of the members of our Technical Assistance Network Cultural and Linguistic Competency Hub. The objective for today is to discuss and learn about the needs and rationale for addressing disparities in access, service use, and outcomes, to discuss how to assess disparities and create a behavioral health disparities impact statement, which for all you new grantees is required to be submitted by, I believe it's November 30th Please check your funding opportunity agreement for that, as well as your notice of award and your government project officer for those dates. We also want to talk about strategies for addressing behavioral health disparities, as well as how to gather, interpret, and utilize disparity-related data on an ongoing basis. So, before this, our webinars are designed for not just grantees, but non-grantees as well, because this is a methodology that could be used to expand and to address all systems of care across the nation. And we also, some of you, I see many of you have joined who have had prior grants. I believe there's about 12 of the 2019 grantees also had 2015 grantees. So you do have a disparity impact statement that you submitted for your prior award. This is a good way to refresh that. And for those of you that are joining us that are in mid-cycle of your grant awards or grant cohorts, this is also an opportunity to re-explore how you can continue to use your behavioral health disparity impact statement for ongoing use throughout your work. So with that, I'm going to turn it over to Peter.
Connect and to share with everyone on such an important and very timely topic. When we talk about disparities, really we get a question sometimes about, well, why is this important, and is this really a priority and things like that. So we really need to kind of take a step back sometimes and talk about rationales or the reasons why it's so important to pursue this type of work. Well, really the core rationale is that the face of America is changing, right? This is definitely something that we're seeing in terms of demographic trends and as well as visibility of certain populations. We're seeing, for example, cities and counties and jurisdictions where there's what's sometimes called a majority-minority population, where there's a 50% or more of a minority group that is the majority of that city or county or jurisdiction. So what type of implications does that have for addressing the needs of these different population groups, and as well as visibility? So we see LGBT populations and their allies are really raising the visibility and the profile of their contributions to society and to what they're doing in their communities. So these types of things are really changing really on almost a daily basis. And when we look at the data, it's really interesting. So the first U.S. Census, it shows us how far we've come. The first U.S. Census was in 1790, long time ago, and there were about approximately 4 million people at what were then in the United States. So then there were these categories, like in terms of the questions that were on the U.S. Census. And the reason why we have a decennial or at every decade census is because it's the U.S. Constitution that says in Article 1, Section 2, that there needs to be a full count of the population of the United States every 10 years. So in 1790, when they were first doing this, they had a certain number of categories, and this is part of the historical record. The number of free white males aged under 16 years and over 16 years old, the number of free white females, the number of other free persons, and the number of slaves. Right? Those were the categories at that time, and we have evolved as a more perfect union since then to have a U.S. Census that is very diverse. There's lots of different categories. There's lots of different options for races and ethnicities. So we are seeing definitely changes in the U.S. Census itself. And now we're a United States population of the most recent estimates provided by the U.S. Census Bureau as of July 1st of 2018 was 327 million people. So we've gone from 4 million from the first U.S. Census in 1790 to 327 million people. A very diverse population, very evolving society that we have. So in appreciation of that evolving society, when we look at the demographic trends, the U.S. Census can really be a very core guide for that. And when we see that there's a demographic trends and an evolution of population groups and different categories of different types of people, it follows that an increasingly diverse population leads to an increasing need to address their disparities and disproportionalities, right, their needs. And so we are working in the behavioral health field, so that is the specific aspect of how we are looking at those disparities and disproportionalities or needs, if you will, of those populations. Just to make a quick note about the evolution of the U.S. Census, in the year 2000, that was the first time that there was a multiracial category that was added. So it's very interesting that we can, from the year 2000, we can now look at trends and changes, and we're going to just take a look at some data sets very soon here and look at how that evolution has changed just in 10 years, just the 2000 to 2010 U.S. Census. And of course, as we know, we have a 2020 census coming up next year. So there's definitely important for people to stand up and be counted and be included in that census. In the year 2010, we had the same-sex household data where there was a question on the questionnaire that asked about same-sex households. So this is something that we're also looking at. We'll be able to look at demographic changes and that evolution over time. So very interesting types of things that we're seeing. So in terms of looking at the data, and I know that the sort of tables on the left are real small, so I'm going to walk us through what we're looking at here. On the left, we have the state-by-state snapshot, and there was only so much room. I couldn't add all of the states, but it shows the regions of the United States in terms of the Northeast, the Midwest, the South, and the West. And then the columns that are shown are the year 2000 compared to the year 2010, and then we see a percentage and percentage change on the very right-hand side. And again, I know that the text is quite small, but what we see overall is that across all of the regions, right, all of the regions of the United States, the two or more races population has increased significantly. So in terms of, for example, the Northeast, we see a change in population of 15.3%, right? And then across the Midwest, it's 41.6%. Among the South, it's 48.1%, right? And then among the West, it's 24.3%. So major changes in people identifying as more than one race. Very interesting to see just in 10 years, right? Huge changes over time. And then again, in the 2020 census coming up soon, then we're going to be able to track that even further. So the map on the right here is a density map. It basically looks at the proportion or the density among the county populations. In the darker green shaded areas show that there's a higher density of people who are self-identifying as two or more races. And there are some states that have sort of white spots or places where there's a less than 1% self-identification rate as a density among that region or among that county. But even if you were to zoom in into those sort of areas that look like there aren't as many people who are self-identifying, when you zoom into a specific county level or a specific state level, for example, kind of zoom into the map, then you see that it is much more colorful as well, where there is, there are spots among these areas. But this is the national map that's showing, that overall we're seeing a very widespread diversity of change. So what's driving some of this? That's the question. It's like, well, this is really interesting. We're seeing these demographic shifts that are very marked. So we're seeing attitudinal trends. That's part of this, where people are accepting or supporting intermarriage, for example. This is from the Pew Research Center. They do wonderful surveys that are tracked to track the data over time. And they did a survey that asked about the percentage of marriages involving spouses of a different race or ethnicity from each other. And as you can see on the sort of lined or run chart on the left, that from 1980 to 2010, just a 30-year span, we can see major changes, right, in terms of the intermarriage trend in our really recent history, really almost more than doubling, if you will. And then in the middle, we have another run, sort of line chart showing a change from approximately 87 through 2009, depicted here, where we can see that it has risen from 48% to 83% of the acceptance of blacks and whites dating each other, right? So this is recent history that's showing a major change from 1987 to 2009 of the major changes in terms of attitudes for blacks and whites to date each other. And then when we ask the question, well, what types of people are, where is this coming from? Well, we find that it's the younger populations, right? It's the youth who are it's more normal for them. It's more sort of just an everyday reality for them to say, oh yeah, they say that it would be fine if a family member, for example, were married to someone of a different race or ethnicity, right? No big deal to them at all. But as we see in terms of the sort of changes of age groups that are depicted here, you can see 18 to 29 is the first at the very top of the right-hand side, and then we move to the ages 30 to 49, 50 to 64, and then 65 plus. It's people are not as much saying, right, that it would be fine. So the older generations, right, these things are changing, attitudes are changing compared to the younger generations. So the youth are definitely driving these perceptual changes over time. So the perceptions and the attitudes are definitely part of this in terms of the intermarriage trend. And then the intermarriage trend is then obviously connected to the two or more races population that's changing over time as well. And if we look at our recent history from 1967, there was a U.S. Supreme Court landmark case, Loving versus Virginia, where it was declared unconstitutional these laws that were on the books in these states where they had what were called anti-miscegenation laws, where the people of a different race could not marry one another legally, right? So that was struck down by the Supreme Court in 1967, and it had already been changing over time. The states, on a state-by-state basis, were striking down those laws, but then it finally moved to the Supreme Court, and then they just knocked it out, and it was done. And similarly, we had same-sex marriage, same type of trend recently, where the state-by-state, there was a trend over time. There were civil unions at first, and then same-sex marriages started to happen, and the laws started to change on a state-by-state basis, and then it went to the Supreme Court, and then the Supreme Court, similarly declared that was it's one of the constitutional rights that people have to marry one another when they're in an adult same-sex relationship. So very interesting changes over time. We also see the Hispanic population is definitely on the move across the United States. This is another example of a density map. This is from the Georgetown Public Policy Review. And so you can see that there are certainly states with much higher densities. But again, if you were to zoom in right into these areas, right, in terms of the Northeast, in terms of the West and the Midwest, right, if you zoom into certain states and counties, then you see that there's much more colorful things that are happening as well. So definitely something to appreciate and something to look at when we look at the data. And from that 2010 same-sex household data, the Williams Institute in California, they are a center that basically crunched all the data from the U.S. Census questions, downloaded it all and organized it and did these beautiful maps. And you can see at the top left here on the slide, there's a similar density map where it shows very widespread number of people who are self-identifying, saying that they're in a same-sex household. And there are some places that, when we work with systems of care, sometimes we'll ask about certain populations, and the LGBT population is certainly one of those populations. And sometimes there will be sort of a perception of, oh, we don't have those people don't live around here. We don't really have those clients, or we don't see those people. They don't really live in our community. Okay, well, that's interesting, because when we look at the data, right, for your region, or your city, or county, or your area, we are seeing those people, right, according to the U.S. Census. So it takes the sort of the bias part of things out of it. The advocacy, is definitely important, and that's certainly something to focus on in terms of, really asking the questions and having the concerns for the well-being of population groups. But when you kind of run into certain situations where, you don't want to sort of address the sort of bias-related things, just use the data, right? Just use it's an objective way to say, well, according to your maps and your area, the U.S. Census data, this is what we are seeing. So that can kind of, be a sort of bridge to make in terms of the use of that data. It makes it more objective. And in some states, when we look at some data around certain populations, there are some surprises that come up, wonderful surprises, where we might not have expected to see that there were lots of certain types of people. For example, in Mississippi, we have a wonderful map that depicts that across Mississippi, there's definitely different regions, different areas that are shown where there's more people who are identifying, as in a same-sex household. And when they were looking more closely at the data, there was even a more surprise as well that came along, where it was found that the Mississippi actually leads the nation, right, in the percentage of same-sex parents. So, and that was sort of something that came up in work groups and in discussions and things. So, again, when we kind of look at the data in an objective way, it's like, wow, that is very interesting when we see these things. So why is it important as well to address disparities and then the needs of these populations? Well, because we know there's gaps within and across systems, right? The system of care is composed of many different child service systems, child and youth service systems, and those that are also serving their families. And what we know is that there's the special education system, for example, the child welfare system, juvenile justice, and child mental health. Right? If we don't address the needs in terms of their unequal access or the use of services or their outcomes and how they do in terms of their use of behavioral health services from birth to death, right? On the very bottom of this, it shows a continuum. So everyone's lifespan is certainly connected, and if we don't address the needs in the child system, for example, when they get to the transitional youth ages, and this is just an example of a range of transitional age. I know that there's different ranges that are used for sure, but this one says 14 to 21. Advocates are definitely, have moved this age across, up to 26 I've seen, and so there's lots of different regional sort of interpretations of what a transitional age youth or age range is. But if we don't address the needs in the child systems in that transitional age, what we find is that there are challenges that continue across a lifespan into the adult systems, right? We see different connection points to the adult systems in terms of criminal justice, the disproportionate use of the adult mental health systems. There's housing instability, there's vocational rehabilitation needs, substance abuse challenges and needs, right, that are happening in the adult, that are being addressed by the adult systems because the child and youth and family serving systems really kind of didn't address the issues that were needed to be addressed early on. So we're always trying to definitely go upstream to have preventative focus, a sort of public health framework on preventing these challenges in terms of their unequal access, use, and outcomes as early as possible. And then another rationale that's very big is that it's embedded into the system of care values and principles. This is something that there's lots of different publications, research, conference presentations, just lots of different resources that are available that echo the system of care values and principles, and that includes that the systems of care are family-driven and youth-guided, that they are community-based, that they're culturally and linguistically competent, and that they're data-informed. Right? So this is core to what drives a system of care. So cultural linguistic competence is definitely a major aspect, of a connection point in terms of why are we addressing behavioral health disparities, for example. And there's research articles, lots of different topics and different aspects of looking at this as well in terms of the outcomes or the results of addressing disparities. There's lots of positive gains in terms of when those gaps are addressed. For example, there's improvements in the overall quality and efficacy of care, the health and well-being outcomes or the quality of life among youth and families, the communication and trust between clients or consumers or people who are being served and their providers. There's provider knowledge and skills that are advanced, as well as client and provider satisfaction that's increased. So lots of different aspects of what the wins around this. And then if we kind of invert this and look at the negative side of things, that there if there are also declines in medical and mental health disparities, right? There's declines in provider bias and discrimination. There are less delays in seeking needed care and services, and then those costs as well are also affected by these improvements. So lots of different aspects, right? Different rationales, reasons, right? Why are we doing this? Why is it so important? Well, there's lots of backup, right? Lots of articles and research that certainly shows that it's important and it has a positive effect. So when we talk about when we talk this language, right? When you start talking about disparities, there's another term called disproportionality, and there's a difference, right? So sometimes we kind of default, and I've heard, oh, well, that's a disparity, right? Or these sort of terms are sort of a catch-all term that's used where everything is sort of called a disparity. That's one way to sort of address the needs of a population. But when we start looking at the language around how we're using the data, I think it's important for us to really have some exact language that's used so that we can know the difference and really help to hone in on what do we mean by that disparity, or what do we mean by that disproportionality? What's the difference between the two? So that's what we're covering now. The disparity, it's an inequality, and it's marked by a comparative difference. So for example, if we were to look at the differences in access to quality care among males versus females, or boys and girls, or men and women, for example, we're talking about a disparity. Or if we're talking about how white youth are accessing services compared to Hispanic or Latinx or African American youth, right? We're actually comparing groups with one another. So that's a direct comparison. It's a comparative difference among those groups. So that's where we're talking about disparities. When we talk about disproportionalities, this is where there's skewed representation of a given population group despite comprising a minority of the overall population. Okay, so what does that mean? That means that, for example, if you have a minority population, right, and they are disproportionately impacted, right, that's a disproportionality. So let's talk about an example, and we're going to go through some poll questions to kind of hone this down even further. So if we were to say African American men represent a majority of new HIV infections, but are the minority of the overall population, right? They comprise a minority population of the overall population, but they're disproportionately impacted by a certain health condition or whatever this sort of social related thing that we're looking at, the disproportionality, then we're really looking at skewed representation. So that's the difference between what a disparity is and what a disproportionality is. I know these concepts are sometimes new and can be confusing. So let's go through some examples. So if you could, some audience participation for us to vote on this. If we were to say racial and ethnic minorities endure higher rates of morbidity and mortality, right, which is chronic disease or mortality, early death, than non-minorities, then what is this? Is this a disparity? Is it a disproportionality? Or maybe you're just still unsure about this. So we'll just take a moment here and we'll see how the poll results add up to click on which one you think that this is. And we have, looks like 91 direct participants today. So that's a lot of participants. Wonderful to have everyone connect and to join us today. So we'll just give this just another moment for these totals to add up. Okay, and it looks like it's slowing down a little bit. Okay, so we're seeing that the majority of people are saying that it's approximately 2/3 of people are saying it's a disparity, right? So let's move to that. Yes, it's a disparity because we're comparing two different groups directly with one another. Right, so racial and ethnic minorities compared to non-minorities. So that's a disparity. So that's great. Let's do another one. Okay, so if we were to say that racial and ethnic minorities experience greater challenges accessing behavioral health services compared to non-minorities, what is this? What do you think this one is? Let's just take a moment and click into this poll. Okay. So as this is filling in, we're seeing about approximately, so more people are about 3/4 of people are showing that it's a disparity. Okay. So then we'll move to that. Yes, and this is another disparity. So again, we're comparing groups directly with one another. So that's a clear example of how we can talk about disparities. Okay. And then we'll do one more. Okay. So now let's say that we have, we looked at the local detention center statistics or data, and we found that they're confining a higher number of African American and Latino youth compared to the racial and ethnic makeup of those youth within the county that is of service there, the catchment area. Okay. And the majority are showing that it's a disproportionality. Yep. So this is the issue with the skewed representation. The way that I think about it is kind of like a pie chart. So let's say we have a minority population that comprises approximately 15% of the county, for example, or the city, or the state, or whatever the system of care coverage catchment area is. So we know that that's a minority population. But then we find that the incarceration rate, for example, among that population is 50%. Well, that's clearly that's a very skewed way that they're being represented in terms of how they're interacting with that service system. So the pie chart way is sort of a way to think about the disproportionality. That's kind of how I think of it visually whenever I'm discussing disproportionalities. Okay, and then to the next one. Okay. Those were our poll questions. So another reason is that addressing disparities and disproportionalities, another rationale is that it's increasingly required by public funding agencies. So SAMHSA, for example, is very much a leader at the forefront of this, where their grants are requiring that their grantees are that they're addressing disparities and disproportionalities. And for example, the Behavioral Health Disparities Impact Statement, which is coming up, it's due for new grantees at the end of November. That is a way to sort of to encapsulate or to put a plan in place in terms of looking at those disparities. So we're going to look specifically at the requirements and then how to collect the data that are around that. And then another reason is that it's not just public funding, right? Also private funders. So your system of care to do fundraising and to have funding for match, for example, match funding and other things to support services for youth and families, that they are also requiring, right, the data to be collected around this. So this is a real opportunity for grantees to really have a solid understanding of the needs of their populations in their catchment areas. And so the private funders, for example, they want to know about the diversity and inclusion of clients to be served, the diversity and inclusion of key staff. They want to see that there's peers sometimes or meaningful involvement of individuals served. And then other types of proposals for funding and other things we see that they're asking for about the diversity and inclusion among their board of directors, right, by race, ethnicity, gender. So these are the types of things that are, this what positions a system of care community very well for expanded funding opportunities. And not just to go after the money, right? It's that the diversity and inclusion is always good for business, if you will, in quotes there. It's just a way of operating, right? That's always very healthy. And so one of the ways that this can be done is that we can look at an evaluation framework where we have process-related data, and we're going to follow up with clients in terms of their first assessment. Here's the arrow at the bottom, the graphic depicted here, where they're going to have their initial baseline assessment from day one into the system of care, and there's going to be follow-up periods that are happening, follow-up reassessments, and we're going to look at their outcomes over time, right? So this is where we really want to know, how are they doing? How are they doing in the system of care? How are these youth and families doing in terms of when we look at the breakouts of the population groups, right? We want to see how different populations are doing compared to others. So this allows us to have a real deeper understanding of the services and the needs among these population groups. And we can conduct needs and resources assessments at the front end of a system of care in terms of looking at local and national data. We can have their funding opportunity announcement response ready to go. The notice of grant award then comes out from SAMHSA and from other funders with terms and conditions such as the requirement for behavioral health disparities, impact statements. There's the submission of that statement, implementation of strategies, right? So it's not just knowing about the disparities, but also coming up with the strategies for how to best address them. So working with those youth advisory councils and family advisory councils to best inform and look at the data with you to say, well, how, we found that there's a disproportionately impacted community, right, in our system of care. How can we best address this need, right? And then they can help to inform that process. And that's really the part of that youth and family driven and guided process in a system of care. And it's also used for continuous quality improvement, right? We want to continually do better on an ongoing basis with the system of care in terms of the services that are provided. So this is an example of a chart that can be done in terms of really estimating what are the numbers of people that we're expecting to serve. Well, according to the U.S. Census data and according to different data sets that we're looking at, we're estimating that we're going to have, for example, if it's let's say it's, I'm just throwing out a number, let's say it's 100 youth and families are going to be served in fiscal year 1. Well, among that, where we look at the data and we show that there's a majority African American population in our catchment area, well then that is going to help to come up with the numbers that are filled in here. So we do it by race and ethnicity, we do this by gender, as well as by sexual orientation and gender identity, the LGBT population, for example. And I've looked at submissions, behavioral health disparities impact statements that were submitted to SAMHSA, and I've reviewed them and I've provided help, and I can certainly review and provide input into the ones that are you're preparing as well. That's definitely an offer that's on the table for anyone who wants me to look at their what they're preparing before it's submitted. That's definitely an offer. And sometimes what I see, and I just want to kind of preempt this a bit, is that sometimes because it's found, oh, we couldn't find the data, right, then we just put zeros, right? So that's kind of not really what we're looking for. That's sort of a flag that gets raised of, well, why didn't you think that you would have, for example, any Asian people in your system of care that would be served in fiscal year 1 or 2 or 3, for example? I say, well, we just don't, we don't see that there's, that population, right? Or LGBT, we just don't know. We don't really have any data to go off of, so they just put zeros. So I definitely want to encourage you to, don't put zeros for sure, because it'll sort of raise a question, and as it should, because it kind of means that even on paper, it's sort of not planned that anybody among that population is going to receive services, and that's definitely not the case, as we know. So, in terms of planning purposes, it's very important to make sure that everyone has a representation. So in terms of the grants that are submitted, your system of care grant, there's guidance that is provided in terms of the funding announcement that this is Appendix G, right, of the notice of the funding opportunity award, funding opportunity announcement, the FOA that came out that was stemming from how your system of care received funding. Within that funding opportunity announcement, there was a sort of expectations, right, set up for how a system of care is, what they're going to do. And so SAMHSA expects recipients to utilize their data in 3 different major ways: to identify the number of individuals to be served during the grant period and identify what are called subpopulations or populations of focus by race, ethnicity, sexual and gender minority groups, for example, that are vulnerable to behavioral health disparities. So having that chart that we just looked at, that table in terms of estimating the numbers across those fiscal years, that's how those numbers can be identified. And then also to implement a quality improvement plan for the use of program data on access, use, and outcomes to support efforts to decrease those differences in access, use, and outcomes of the service activities. So what does this mean? That means that having a plan in place, right? And the plan might be, We're going to work with our family advisory councils, our youth advisory councils. We're going to have subcommittees, right? How that looks is going to be different across different systems of care in terms of the specifics, but certainly having a quality improvement plan means that there's a plan in place, that there's going to be strategic planning meetings, or there's going to be, right, involvement of key community members, right? That's how the plan will be rolled out in terms of looking at those disparities and using that data in a meaningful way. And the third item, the expectation from SAMHSA, is to identify methods for the development of policies and procedures to enhance what are called the class standards. And this is the National Standards for Culturally and Linguistically Appropriate Services in Health and Healthcare. Long title, I know. It's called the class standards for short, and we're going to have a slide on that in just a few. But the class standards are basically a framework that helps the U.S. Department of Health and Human Services grantees to address a framework for advancing class across the United States. So the definition of health disparities comes from Healthy People 2020. That's a guiding framework for the U.S. Department of Health and Human Services. And it defines a health disparity as a particular type of health difference, right, that's closely linked with social, economic, or environmental disadvantage. Health disparities adversely affect groups of people who have systematically experienced greater obstacles to health based on their racial or ethnic group, their religion, their socioeconomic status, their gender, their age, their mental health, cognitive, sensory, and physical disability, sexual orientation or gender identity, geographic location, or other characteristics historically linked to discrimination or exclusion, right? So this is the drivers for disparities, and so these projects or programs and systems will address those disparities. That's the expectation. So the terms and conditions that come out as you have your congratulations moment and you've received funding for a system of care, right, or in other types of grants, that you need to now submit a behavioral health disparities impact statement, right? So the disparities impact statement, I'm just going to highlight some of the terms here, that you will have that statement or a submission of that statement that's going to address those needs among those populations in terms of their data collection activities that you will be undertaken, the program services and activities, development, implementation, and then how the data will be reported, including the access, use, and outcome measures. And then the plan is to address how class is going to be incorporated as well. So again, it's like high-level, right, concepts that are the details come out in the planning and in the meetings and the follow-up and the use of that data to say, okay, now we know that there's, right, a higher incarceration rate, for example, among this population, where school dropout is really high among this certain population, for example. So what are we going to do about it? Well, we're going to work with our committees, we're going to work with our youth and families directly to come up with strategies and ways that this can be done to address those needs, right? That's where the details come through. So the requirements here are that SAMHSA grantees in any system of care needs to provide culturally competent, evidence-based mental health services to children with serious emotional disturbances, develop a behavioral health disparities impact statement no later than 60 days after award. So it is coming up the end of November. And then report on the following performance measures. And these are the national outcome measures in terms of their diagnosis, mental health, mental illness symptomatology, employment, education, crime and criminal justice, their stability in housing, rates for readmission to psychiatric hospitals, social support and social connectedness, and client perception of care. These are the surveys that are entered into the SAMHSA data online data system. So every client, right, every enrollee, they're going to receive their assessment that will address those national outcome measures that are listed here. So performance assessments are required for SAMHSA grantees and are useful to any system of care in order to periodically review the performance data that's reported to SAMHSA, assess the progress, and use this information to improve the management of the grant, assess and report on progress addressing goals and objectives identified in the grant applications and whether adjustments need to be made, determine whether the grant is having or will have the intended impact on behavioral health disparities, and submit their annual progress report or annual report on the progress achieved, barriers encountered, and efforts to overcome these barriers. So there's ongoing reporting, right, in terms of the responsibilities to report this upward to the funder. So ensuring access to quality, culturally competent care is definitely a component. Serving culturally and linguistically diverse communities, not just defined by race or ethnicity, but also their socioeconomic status, sexual orientation, gender identity, physical and mental ability, age, and other factors, and using data collection instruments that adhere to culturally and linguistically appropriate norms. So what we want to do with our behavioral health disparities impact statement is develop to assess and heighten the impact of policy, programs, processes, and resource decisions to reduce and eliminate behavioral health disparities. That's its core purpose, right? That's a very technical, I know, description of this, but that's really the source, the documented reason why this is so important. And behavioral health data, we know, are often isolated in agency silos, for example, that are used for a singular purpose, like for reporting to one funder, for example, or to address a specific policy. But what we want to ideally look at are disparities and disproportionalities to address those differences in access to services, in asking the question, who are the populations of focus that are enrolled in programs, right? What do we know about them? What types of service use do they have, and the differences in that service use, right? Who's getting what kinds of services, and how is that comparing to one another? And those outcomes, given the specified outcomes of a program, how do these vary? How do they differ? Maybe African American males, for example, are not doing as well in their services compared to African American females, or maybe the Latinx population is not doing as well. They're dropping out of services compared to the white youth, for example, right? So these are the types of things that the data can really help to illustrate and to highlight. And then, again, you come up with those continuous quality improvement strategies on how to address those differences. So some of the strategies. So how do we get these data? Like, where is this going to come from, right? So strategies for gathering and interpreting data for addressing disparities are to certainly start with the data that are already available, right, publicly available. The U.S. Census data is very central to this in terms of looking at the U.S. Census demographic composition of your catchment area, right? And also looking at some state data. There might be state reports, for example. And then you also have your own agency services data, right, in terms of your electronic health record, or maybe your data management system can have a report that can break out by race, ethnicity, gender, sexual orientation, right? So you're already collecting a ton of data. Why not have it, sort of divided out and have those reports be able to look at those population groups in individualized ways? And then there's training evaluation data, right? So on your training evaluations can have a demographic section, for example, to show which types of people are receiving which types of services. There was a cat in the background there. So collaborating with community partners, youth and families, professional community leaders, and service providers to gather local data. So working with your system of care communities to come to your council meetings to look at those data and compare with the national and aggregate data. Okay. Sorry, I had to take a toy away from the cat in the background. Okay, so the data after the data are gathered from various sources, then we look at those disparities data and then have those strategies, right? So what are we going to do with it when we know that there's a disparity? We've identified a disparity among the population. We're going to interpret those data to look at the cultural and enrichment needs of the community, the gaps in services for minority populations and other underserved population groups. We're going to ask questions about whether services provided are client-centered, right, youth-guided and family-driven, and whether services provided are culturally and linguistically competent and aligned with the class standards. So the class standards are a framework that is provided, and here's a link. You can go to Think Cultural Health, the website there, has the standards and explains the specifics around what they're all about and what they're intended to do. And basically, the principal standard is to provide effective, equitable, understandable, and respectful quality care and services that are responsive to the diverse cultural health beliefs and practices, preferred languages, health literacy, and other communication needs. So you can definitely sort of read all about and investigate further, what the class standards are entailing, but it provides that helpful framework for addressing services in a way that's culturally and linguistically appropriate and competent. So here's an example of how we do this in terms of our evaluation work when we come up with a behavioral health disparities impact statement. There's two sections. We have a background section of our disparities impact statement, and this has the statistics on the overall disparities and disproportionalities among a state or a region. What is the population, what are the needs among the population groups within our state and region? The statistics on the program service area disparities and disproportionalities according to race and ethnicity and LGBT were available. So for example, can we get the school dropout rate report right locally? Do they break it out by race and ethnicity? Do they have LGBT, right? Do they have other populations that are being addressed? Can we look at the housing instability data for our area? Can we look at the mental health needs or other juvenile justice reports, right? So there might be other reports among different system of care communities that are available where they're breaking out by race, ethnicity, and gender typically, but maybe they aren't addressing LGBT. So maybe at your meetings with your system of care communities, you can show them, well, here's the type of data that we're collecting, and it'd be great to know, the disparities among these populations, right, among their system as well. So it could be a collective effort to address those needs. And then part two is the impact statement. It's specific information regarding the populations in the service catchment area or the geographic service region. We're going to use that for data collection and reporting, and then we're going to have plans for specific policies and procedures to address disparities and disproportionalities. So that's how we're going to have an impact on the disparities and disproportionalities. So here's an example of one community called Infusion, where they had a behavioral health disparities impact statement with a specific defined population that would be served, youth and young adults ages 14 to 21 with serious emotional disturbance who are transitioning from child mental health services to adult mental health services and or from an institutional setting to the community. That was their specific population. And then we wanted to know about the statewide and local context and need. So we looked at mental health and behavioral difficulties among youth, appropriate treatment for youth, the juvenile crime and mental health concurrence, training schools that were available or not available in the area, community services that were available, mental health in the juvenile justice system. We looked at school dropout rates, teen pregnancy, unemployment, homelessness, right, or out-of-home placement, the foster care and adoption systems, right? What types of things can we look at in our system of care in a wide way to basically understand what is going on with these specific children, youth, and young adults and their families, and then how can we address those needs? So again, it's to link all the systems together to address those needs. And so, for example, we looked at some census population data side by side, where we looked at the Hispanic and Latinx population, or what were collected then in this data set were the Latino population, and then we looked at the language other than English spoken at home. This is publicly available on the U.S. Census data sets, and then we looked at across these counties that there was a population in need. Right, so we found, for example, in Scott County in Mississippi, that there was 10.7% of Hispanic and Latino population in that area, and then we found that there was also another high percentage of a population that were speaking a language other than English at home. So what it found is that it drives the strategies. Well, we're not really seeing that. We're seeing many Hispanic or Latino youth that are coming in for services. Well, maybe we need to have a Spanish interpreter, right? We need to have our materials that are translated. it can help to drive those strategies to better address the access points for that population. And then here on the right-hand side, it was a specific, you can even have potentially more specific population groups as well. And then we looked at data, for example, on the African-American youth in the juvenile justice services systems. And again, by a county, we found some county-level reports. And then we compared that to all other youth combined. So we found that there was a major disproportionate number of African-American youth that were entering the juvenile justice system compared to all other youth. So it begs the question, well, okay, how can our system of care, right, address this need? This is definitely something that is a highlight when we look at the data. So then what are the strategies that are used? And again, in terms of the nearest population number, we can then compare those across counties in terms of populations and find sometimes very large percentages that are very obvious. So sometimes, when you're working with youth and family advisory councils, right, you don't want to present like lots of tables of data and lots of, like here's our, like very complicated data information, that is not everyone's cup of tea sometimes. So we want to definitely have a translation of that information into things that are like infographics or ways that the data can be visualized, right, in an interesting way, and focus on, how we can have a discussion around it. So these are examples of the fact sheets that are basically generated to highlight specific types of topics, specific types of needs. So we looked at educational school dropout versus graduation rates, right? That could be one topic of one youth advisory council meeting, or that's their major topic they're going to focus on. Or it could be teen pregnancy, for example, or gang violence and substance abuse, or any number of disparities topics, right? These are lots of different rich areas for discussion. And then in your trainings, sometimes there are cultural linguistic competence trainings that are offered. This is an example of Albertine Johnson Pickett's cultural linguistic competence sessions where she's going out and providing lots of diversity inclusion trainings and cultural linguistic competence trainings. And we wanted to know, is it making an impact, right? What's the data show? And so we asked people to identify their commitment to cultural linguistic competence before the training versus after the training. And so we were able to map this onto a nice chart that's shown here on the left, where it shows that before levels of commitment, there were some slightly committed and more moderately committed, right, number of individuals. And then after the training, it was indicated there was a major sea change, right, a wave of commitments to addressing these issues because they were raised, right, as a need. So then it shows that there's an impact, right, of the training. And then there's qualitative ways to also ask for this. We ask people to provide a specific example of how to apply the information from their cultural linguistic competence learning sessions that they had attended, and had wonderful write-in responses where people, really took the time to sit and write out, the types of impacts of how to apply their information they gained. So they're saying, for example, we're going to be able to better have efficiency and coordination of services. They can be used in our outreach and prevention efforts. They're going to better relate to consumers of different cultures other than their own, right? Lots of wonderful outcomes that are coming out of these trainings. So it really shows the value, of what can be achieved. So in terms of data-driven strategies, you want to have these regular data reports, certainly working with your evaluator to basically try to look at that data as much as frequently as possible to generate things that the youth and family advisory councils can use. For fact sheets are just an example of that. There can be other types of efforts, presenting, for example, at statewide conferences, or presenting right in their local communities, coming up with lots of different resources to use that data and discuss that data and come up with those strategies. And then assisting and discussing the data with stakeholders, excuse me, for those other system of care partners, and developing population-specific strategies to address disparities in their access, use, and outcomes, and having that client-centered feedback loop right, to ensure that there's an influence on positive impacts and service delivery for the youth and families receiving services. So these are the strategies for what we want to do to improve service performance. So what are the steps? What can we do specifically to do this? Well, one is you got to update your forms. You got to have somebody to be able to self-identify who they are in very specific ways, to collect inclusive data that are reflective of the change to grant requirements, for example, in identifying disparities. Here's an example of language that was in system of care projects, for example, where there was a directive to identify the catchment area and provide demographic information in terms of their race and ethnicity, federally recognized tribe, language, gender, age, socioeconomic status, and sexual identity. Right. So what are the things that are known in your community about your population of focus? So the forms are really needed to be updated, and sometimes agencies are using paper-based forms. So maybe tracking down the template or making a change to that form is really needed. And sometimes when you get to the LGBT-related questions of how data can be collected on that population, sometimes we hear, well, we don't know how to ask that question. There's lots of examples of how this has been done successfully. The National Health Interview Survey has measures for sexual orientation and gender identity. For sure, there's lots of different examples and best practices for how to ask that sort of LGBT questions. Also, to conduct an anti-discrimination policy review. This is important to determine whether policies are inclusive. So, for example, our staff who are allies and really want to work on disparities, do they feel supported at work? Can they feel like they are supported by their administrators or by their agency? So by having a policy in place, this can really help. And then also looking at partner agency policies. So, for example, youth and families may be very well supported for diversity and inclusion within your sort of four walls of your agency, but when they're referred to the housing provider down the road, or the state mental health hospital, or other types of service providers, the juvenile justice systems and other the school systems, what do their policies look like? Is that referral, are they being sent to a place that is as inclusive as your own agency? So maybe when you're having your community meetings with your system of care partners, to encourage them to look at their own policies for inclusion, diversity and inclusion, and then to update those policies. And then vendor contracts as well can be done to include anti-discrimination language. Another aspect is to expand safe zones or safe spaces for all youth. There's safe zone trainings that are available. There are universities that provide safe zone trainings. There's lots of different resources online for describing safe zones and what they represent and what they mean, and also to designate safe zone areas. So a safe zone is basically a place where people feel that they're supported and know that they're going to be supported for who they are. And sometimes they're very colorful. It can have graphics and images of diverse types of people, or different colors, right? For example, the lower left-hand corner is just having a safe zone sign on the wall or in the waiting room area, or maybe the youth drop-in center has a sign on the wall, right? A safe zone sign. Sometimes it's just words that are depicted. For example, in one community, we saw that they had a safe zone sign that's represented here toward the middle, and it says, "This space respects all aspects of people, including race, ethnicity, gender expression, sexual orientation, socioeconomic background, age, religion, and ability." Like, wow, that sounds like a pretty safe place, right, for people. So these are the types of signage, the types of assurances that can be displayed openly, and really showing that this is a real place that's welcoming and is a safe place for people. And there's lots of other examples of how to implement changes within a system of care or update things in terms of providing training opportunities on selected topics, right? It might be homelessness, right? Homelessness among racial and ethnic minorities, or homelessness among LGBT youth, suicide prevention or bullying, right? That might be affecting different populations in different ways. right? Specific population trainings or different topical trainings can be provided for learning events in your own system of care in terms of webcasts or webinars and other things, sharing them with your partners, right? That's definitely one strategy for addressing disparities. And then sharing that learning content with other types of system of care providers, having inclusive referrals in place, partnering with community alliances, identifying local inclusive success stories, and providing self-assessment tools, right? This is not like you have to do all this on day one, right? This is a strategy across the multiple years of your system of care of the types of things, right, that you have sort of on the drawing board or in the strategic planning idea board for how you're going to address those disparities. And so these are the types of things that would be listed in your behavioral health disparities impact statement. Like, we're going to pursue training opportunities among these topics across, over the next 4 years. We're going to have, improve our referral channels with our system of care partners, right? We're going to have fact sheets on specific disparities. Those are all specific examples that we've covered in terms, and it just depends on, how you do your write-up, right, in terms of what types of activities you want to do. But you've got this major opportunity to do a really creative, incredible work to address disparities that are in your community and the disproportionalities among youth and families. Asset mapping is another type of example. Train-the-trainer resources, connecting with other systems of care is definitely encouraged and advanced. Something very much makes SAMHSA very happy that systems of care are working with one another across states, for example, and showing those successes to one another and learning from one another. And then having social marketing activities to change voluntary behavior toward acceptance and inclusion, right? So the voluntary nature, we're not trying to change people's, their beliefs or their values, for example, but their behaviors, right, of how they're treating people, if there's a certain bias or certain issues there, right, that's not what we're trying to change is their beliefs. It's trying to change the behaviors because we know that those behaviors will have an impact, right, in terms of how vulnerable youth and families are receiving services. So that's the component of how we're looking at behavioral health disparities, why it's important, some specific strategies, and then next steps for how to implement those strategies. And again, I'm definitely going to offer as an ongoing resource to you questions. We can set up a specific TA network phone call or provide resources and other examples. I'm happy to do that. So that's definitely an offer that's on the table. And I'll hand it back to our facilitators of this session. Thank you so much.
Thank you, Peter. That was fabulous. And I do have to comment, we saved 15 minutes for questions, and you nailed it absolutely on the button as far as timing. You're a pro. Thank you for joining us again, Peter. So does anyone have any questions for Peter? Feel free to put them in the chat box. And I do encourage, Beth and I both encourage you to take Peter up on his generous offer in asking for a technical assistance call with him and or asking him to review a draft plan or to review and help you update a prior plan or to look at your data. With these grants no longer requiring national evaluation components, that does give you more latitude with your up to 20% allowance of grant funds to spend on data collection and evaluation to really dive in deeper into looking at your disparate data and then measuring your strategies to address those identified. Looks like we have a couple folks that are typing in. Can we receive a copy of this PowerPoint? Yes, Leanne, if you look in the file box just below the tool, the chat box, you'll see where you can download both Connecticut's tool as well as the PowerPoint. And it looks like Charla may be submitting a question to us. Peter, does the Culture Linguistic Competency Hub have some sample statements that they could share with folks?
We do, absolutely. Yep, we have a resource library, the USF Resource Cultural Linguistic Competence Hub, a resource library, as well as specific, we can email specific people as well for those examples. So please feel free to contact us directly or to go to our website and the resource library as well. And then again, if there's questions about how to use those resources, or maybe it's a specific population with more specific technical assistance need, then we're happy to connect with you directly and to address how to address that need.
Great. And I went to the next slide where Peter referenced the resource library. That link is available on this final slide. And here we have a question from Charlotte. Would geographic disproportionalities be acceptable? Example, number of providers in an area with this percentage of a vulnerable population is lower or higher than another region?
Yes, absolutely. Rural and urban is definitely an aspect of looking at disparities. Services that are available or not available in a certain area. There might be, youth and families may have to drive for miles and miles to receive services. That's definitely a disparity. So that's absolutely a specific aspect of looking at, the needs among that population. Yep.
Great. You're very welcome, Charla. Does anyone else have any questions for Peter? Then what we can do is wrap up. Please stay on the webinar line online so that you can complete our survey. We really do appreciate your feedback. I'd like to thank again my partner Beth Struhl in helping organize and lead this learning community. Thank Tiara for her technical assistance, because I am not the technology pro and we can't do these things without you, Tiara. And thank you, Peter, for joining us today and presenting. We really appreciate everyone's time today. Please continue to reach out, and good luck with your new awards, and welcome back to those of you who are joining us for a second or third or fourth year. We appreciate your time.